In this video, we're talking about what we wish men knew before they embarked upon hormone therapy. Many men are injected upon going to the doctor or handed a bottle of pills, and they're never told ahead of time what to do about these side effects or even that these side effects are about to happen. So today, we've read hundreds of comments from our YouTube channel, and we're going to have 30-year medical oncologist Dr. Mark Scholes, who's focused solely in prostate cancer, answer these questions. Things like what to do if you have hot flashes, what we wish men knew ahead of time, how important is weight training, and how do you do that when you feel so much fatigue? We're going to go through the ins and outs of it, but Dr. Scholes has handled hundreds of hormone therapy cases, and so his experience is going to be very beneficial in this process. We have been covering hormone therapy for years on this channel, and it is a massive topic in prostate cancer, as you well know, because so many men do go on it. We have first-generation hormone therapy and second-generation hormone therapy, and this video is really focusing primarily on the side effects. However, we will go into PSA. Now, when it comes to the side effects of hormone therapy, before we go into these questions, can you just outline them for patients? And there's not really a big difference between first generation and second generation, but I think if you outline it as these questions go on, we can help build out the context.
I tell patients there are three primary side effects that invariably present when blocking testosterone. Loss of sex drive, which doesn't mean an incapacity to get erections if you use Viagra and Cialis. It just means the lack of interest. Weight gain, which is commonly due to an increased appetite. People just want to eat more. Also, their metabolism slows down with the low testosterone, so even if they eat the same amount they have always eaten, they can put on more weight. And the third, and maybe the most important of all, loss of muscle, which can be very dramatic. And the way men perceive that, if it happens, is fatigue. There's a long list of other things that happen, but those, I call them the big three for side effects of hormone treatment. And yeah, if we go into every detail, we're talking about 10 or 15 different lesser issues, but we'll cover those big three need to be right up front when people are thinking about going on hormone treatment.
So one of the questions is from somebody who has not yet embarked upon hormone therapy, and we talk about the difference between libido and potency, so they're kind of wondering how will they be affected either in one category or both if they do take hormone therapy.
It's rare for men to not completely lose their libido. Libido is the interest or the desire to participate in sexual activity, and that usually evaporates completely. There are exceptions. I don't understand why 5% of men don't lose their libido. Most men, when they embark down this pathway, I think are secretly thinking, well, he doesn't know how strong my libido is, and that won't happen to me. But when we see them a month or two later, they're wide-eyed and amazed at the just total lack of interest in sexual activity. It does reverse when men get their testosterone back. During the time the testosterone is low, typically most men have completely lost their interest. Potency, the ability to get an erection now with modern Viagra and Cialis pills, is still achievable. And in fact, we recommend that men take these medications to get erections periodically, because the normal processes that are occurring for guys is they're getting erections at night while they're sleeping, and that often disappears when men are taking hormone deprivation. So to compensate for that loss of the normal exercise patterns of nighttime erections, it's probably prudent to take some Cialis or Viagra and artificially induce some erections periodically while these men are getting hormone treatment.
I want to remind you, go to pcri.org and register for our in-person prostate cancer patients and caregivers conference here in Los Angeles, California. We want to see you there. Also, please click that subscribe button, because when you do this, it tells the YouTube algorithm that this video was helpful, and they'll push our videos out to other people who need help when it comes to prostate cancer. And you can donate and join our cause at pcri.org/donate. Now back to my conversation with Dr. Scholes. A lot of these men who are embarking upon hormone therapy have already had previous treatment, and some have suffered sexual side effects due to previous treatment. And so maybe they've already had Cialis or Viagra. Would you encourage men who are going on hormone therapy and those pills are not working to look at penile injections?
We do, and that's, of course, a real daunting prospect in someone that doesn't have a libido. It's a daunting prospect for men that do have a libido. The penile injections are very effective, And there's a number of men that are using them and very happy with the results and the effectiveness of them. But it's a real hero that can start on that process at a time where they're kind of wondering, well, why does sex even matter? It sounds very practical and sensible to do, so that men who've been on hormone treatment for a long time, haven't been getting erections at all, don't develop irreversible atrophy problems where if they were getting erections prior. What you're talking about, of course, in men that have pre-existing erectile dysfunction and maybe are already familiar with getting injection therapy to correct that, it's certainly feasible for them to continue on that process.
So another question that often comes up is the idea that, because they've had previous treatment, there may be shrinkage because of the lack of having those erections. Does hormone therapy make it even more extensive with shrinkage, or is just the normal atrophy from surgery or radiation common?
I'm not sure that people know how much each of these things contribute, but it is well documented that previous surgery can cause shrinkage of erections, and that ongoing hormone therapy without any kind of corrective measures can cause shrinkage of erections. And is it additive? I don't think we have the data on that, but it's a problem. And for example, if someone's recently had a radical prostatectomy, it often isn't talked about, but if men during that down period after the surgery, when they're not getting erections, are willing to initiate injection therapy, their chances for long-term recovery of erections is much better. So if we think of erections as sort of another type of muscular activity, just like we're encouraging men to do weight training when they're on testosterone deprivation to maintain their muscles, some sort of activity to restore erections is important to maintain normalcy in that area as well.
Many men who have not yet embarked upon hormone therapy have great concern about the side effects because they're going, I don't want to deal with all this. This can change my life quite radically. And a lot of times it's difficult to think about those side effects in regards to the effectiveness of the prostate cancer treatment. Can you speak to how effective hormone therapy is against prostate cancer?
This is why anyone who's considering hormone treatment, they have to look at potential side effects and also the anti-cancer efficacy, which is undeniable. And we wouldn't be bothering with this stuff that could cause all these side effects if these medicines didn't have dramatic anti-cancer effects. For example, if some man who has had surgery has a rising PSA, we know their cancer is coming back after the surgery. Historically, we didn't have PSMA PET scans and a lot of other fancy stuff that we have today. But with a combination of first and second generation hormone treatment, those individuals can be put into remission for an average of 18 years with simple testosterone deprivation. That's an amazing capacity to control cancer, which doesn't exist for other cancer types, sadly, only for prostate cancer. So when you have something that has that much anti-cancer horsepower, especially in the men that have higher Gleason scores or early spread into lymph nodes, the idea of going after these cancers with aggressive anti-cancer therapy, which typically has reversible side effects, unpleasant side effects when you're getting it, but typically reversible. It's certainly a logical question, and it's not something you want to just automatically assume you shouldn't do it. And then, of course, with any powerful treatment, there's a danger of overuse and using it in men that don't really need it. And this is coming up now more and more with these new PSMA PET scans that are helping us be more confident that there's no metastatic disease. And so the historical norms of giving everyone with a Gleason 8 18 months of hormone therapy, or everyone with intermediate risk disease 6 months of hormone therapy, I think that policy needs to be called into question, given the fact we've got these new scans helping us to be confident that metastatic disease is much less likely.
How soon can you see hormone therapy be effective against metastatic disease on a PSMA scan?
When people embark upon hormone therapy, we usually would reevaluate their status on a monthly basis, seeing how quickly PSA declines. And PSA usually declines about 90% from the baseline after 1 month. And we'd like to see it drop to less than 0.1 within 4 to 6 months. We're not usually repeating scans in shorter intervals. Men who have a PSA that initially declines and fails to keep declining, those men need another scan for sure to see what has gone wrong. It's unusual unless people are starting with very, very high PSA levels, hundreds and hundreds, that you wouldn't be able to get the PSA down to less than 0.1 within 4 to 6 months. So follow-up scans are typically reserved for when the PSA is misbehaving.
Some of the comments that I've read from men who have undergone hormone therapy is that it has greatly affected their marriage, and they have, talked about how the sexual side effects, the change in intimacy, or even just their own personality has changed due to the hormone therapy. How do you counsel couples ahead of time, or do you have any advice to these couples who are going through marriage difficulties because of the hormone therapy?
That, unfortunately, oftentimes is something that doesn't come up in conversation. With all the complexities that are associated with hormone treatment, all the many different side effects, there's a lot to learn about how to anticipate what people are getting into. And there are compensatory things that people can do. We've talked about taking Viagra, but I think people are caught so off guard with the disappearance of the male libido, and sometimes they're not even warned in advance. They just embark upon treatment, and all of a sudden they're in the middle of this and no one's explaining it. The educational process of all these different potential side effects and how to compensate for them is essential, so it can be sort of a couples project in terms of working through this. Ideally, of course, limiting the exposure time as much as possible and making sure that the doctors aren't just following some old protocol of giving people 2 years of hormone treatment because they had a Gleason 8. That is probably no longer necessary in many people, and to get off the medicine sooner would be a big plus as well.
Over and over again, we see men talking about cognitive issues that they're experiencing. And back a couple years ago in Yahoo News even, we were seeing that there was an article that came out that said that hormone therapy for prostate cancer could possibly cause Alzheimer's. Now, is this true? And if they are having cognitive issues, is there anything that they can do to help mitigate those side effects in the process of their daily lives?
The complaint that, particularly like word finding, where men say, I'm searching for words and it didn't used to be a problem for me, is a complaint that I hear. The idea that mental performance is not as good. Testosterone is a performance hormone, and we talked about loss of muscle. I think a lot of the mental performance is partly due to reduced physical capacities. The example I give, when people meet some new people at a breakfast and they can remember their names, and then they have a long day at work, and then they go out for a dinner party, and it's 8 o'clock at night after a long day, and you get introduced to new names, and those names just don't stick with you. You're tired. Men that are deprived of testosterone don't have the same resilience and capacity, and memory is a strength function. And this phenomena has been observed and reported. It's reversible. There's no evidence of men being associated with any permanent damage, but while their testosterone levels are low, and particularly if they're not willing to compensate and pursue fitness training, they will probably notice a reduction in their mental energy and endurance. The other subjective mental thing that men report is a stronger awareness of their feelings. Testosterone puts sort of a damper on feeling intensity, and when this disappears, men are surprised to all of a sudden be crying in a movie or something of this nature. Some men enjoy it, some men don't really care that much, and others are a little bit thrown off by it. There are medicines that you can, small amounts of Celexa or Zoloft, that can help people feel the way they used to feel when they had testosterone if they prefer that. Again, this is all reversible.
So in regards to Alzheimer's, though, it doesn't cause Alzheimer's or have any permanent side effects that would cause, because you said it's reversible.
Yeah, there have been some complaints about database studies where people seem to have long-term memory problems. I've been describing the short-term ones when men are on this, but remember, sometimes men with metastatic disease remain on hormone treatment for the rest of their lives. So you could argue in those circumstances that they're going to have a permanent reduction in performance because they continue indefinitely on treatment. But if they have the good fortune of being able to come off the treatment and get their testosterone back, their mental performance will go back.
So you mentioned weightlifting in that process. Does the weightlifting directly affect the cognitive delays?
It does, and actually this is a pretty well-known medical fact that not only men who have low testosterone who do weightlifting and fitness training are going to improve, but if you look at the problem with memory loss with aging, which is a pervasive issue as people get older, there's really only one thing that's ever been shown to compensate for that memory loss, and that's fitness. Physical fitness has unmistakable ability to forestall memory loss and improve memory compared to people that don't pursue fitness.
I appreciate you mentioning that. We do have a weight training protocol that we'll link in the comment section below because I think it helps people just kind of have something to follow. I know there's a lot of free YouTube trainers and things like that and resistance training that they can do online. Another question that we have is in regards to dosage. So many men are wondering, if they have a standard dosage that they're typically given from their doctor. If they have less of a dose, half the dose, does it make it more tolerable? Will it still have an anti-cancer effect? Would it make the fatigue and the hormone issues, not as intense? And so how often do you change dosage in your practice? And is this really practical over time?
In general, the dosage doesn't matter because the net effect of effective hormone therapy is the removal of all testosterone. So if you take a half dose, but the testosterone is still 100% removed, it doesn't really make any difference at all. We do sometimes temporize with a medicine called bicalutamide or Casodex in elderly men who may have rising PSAs after surgery and they're in their 80s, and we're trying to balance out all these negative side effects with the desire to still control the cancer. Bicalutamide's kind of interesting because it doesn't remove testosterone. It blocks the testosterone receptor. So when you check blood levels of testosterone in people taking bicalutamide, their testosterone levels are actually higher than normal. But all that riches of testosterone aren't really being felt by the individual because the receptors are being blocked. But the blockage is not as complete as it is in other types of hormone treatment where the testosterone is completely removed. And therefore, the side effects are milder. So sometimes we'll temporize with that. It's also less effective, but we can live with that lower anti-cancer effectiveness in men that maybe have sort of an indolent cancer, who are elderly. And we figure we can keep the disease under control for 5 or 10 years with bicalutamide, and if someone's already in their 80s, and it's a reasonable trade-off in people that must have some hormone treatment, but you don't want to hit them with a full dose of regular hormone deprivation.
Is one hormone therapy better than another in regards to side effects? Does one cause less fatigue, or maybe, do you have faster testosterone recovery with another?
There's a lot of issues there. A new pill out called Orgovix has more predictable testosterone recovery when the treatment is stopped. Xtandi, which is a very popular second-generation hormone therapy, sometimes is associated with unexplained fatigue that's a little worse than other types. So there's quite a few choices that are available to people. The side effects that you look at for hormone therapy are pretty much the same for most of the medicines, with occasional exceptions that you do need to be familiar with if you're on specific medicines.
If somebody is starting to become hormone resistant on a drug like Xtandi, and all these hormone therapies typically work the same, then why would a doctor switch them to Zytiga or something else if they all work the same but the PSA is still going up?
The reason that the doctor would switch them is sort of a Hail Mary long shot that particular individual has a subtype that for some unexplained reason would be sensitive to a switch. Occasionally that happens, maybe 10-15% of men. You can switch them from Xtandi to Zytiga or Zytiga to Xtandi, and you'll see some benefit. And it's not a difficult thing to do, and the pills don't have unexpected side effects. So convenience and the hope that you'll get some mileage out of another medicine is attractive, because beyond that, you're looking at oftentimes taking chemotherapy and medicines that have a lot more side effects. It's not a policy that I pursue typically. If someone's developing progressive disease on Xtandi, Zytiga, Nubeqa, or Erleada, then we are concerned that that's a type of cancer that's pretty serious. And fiddling around with just switching to another pill is not a policy that we would usually pursue.
So in regards to weight gain, because we do see a deterioration in muscle and we do see a increase in weight gain in hormone therapy patients due to the lack of testosterone, we now have this new world of GLP-1s and semaglutide, and we see that a lot of men are on these types of drugs, but those drugs particularly also eliminate muscle mass because they're losing weight, and a lot of times they're not able to keep it up. Would you say that patients who are on hormone therapy and these types of GLP-1s, it's essential for them to do weightlifting in order to increase muscle mass? And does it affect bone at all?
Honestly, not familiar with whether or not it affects bone, but I think we can argue, people get into my age group, if you're not doing weightlifting, then you're really cheating yourself out of optimal survival, optimal quality of life. the studies are showing that the difference between people who pursue fitness and those who don't pursue fitness in the over 65-year-old age group are sacrificing survival expectancy of about 25%. It's a very substantial difference, and we kind of all intuitively know that that's probably true. It's just that these fitness programs are rather challenging to pursue and sustain. It's not an easy fix, but those that are able to do it will certainly benefit.
Another comment I saw was from a caregiver, and their dad is taking an oral medication, an oral form of hormone therapy, and they're wondering, is it better to take it with food or without food? They read somewhere that maybe it was more effective with food. Is that accurate?
Well, there's a number of different oral therapies. It turns out that one in particular, abiraterone, also known as Zytiga, is absorbed into the bloodstream much more effectively with food. And interestingly, the manufacturer recommends that the medicine be used on an empty stomach for consistency of absorption, perhaps. Those that are trying to save money can take smaller doses with food, and studies indicate that it's about equally effective. So food does matter with abiraterone or Zytiga, and usually that's stipulated very clearly on the bottle when you get it from the pharmacist. But for the other medicines, they're very user-friendly, and whether you take it with food or not doesn't have a material impact.
So I know we've covered it in other videos, but I want to make sure we mention it in this one specifically because we are dealing with hormone therapy side effects. Hot flashes happen to a lot of men who undergo hormone therapy, and I want them to know about different things that they can do to mitigate those issues, because I find that some men are commenting and they don't even know that these types of patches or different creams and things exist. And it's important because a lot of these guys are going to work and they're having multiple hot flashes a day or waking up in the middle of the night. And so anything that we could do to help them, we should.
Pharmaceutical companies are working on some new medicines, and I think there is one approved now for women. I don't remember the name of it, and it would be kind of pricey because it would be off-label in men. I haven't used it. I had one patient request that I order it for them a month or so ago, and I'm not sure if it's going to be effective, but I suspect it would be. What we've usually defaulted to when we want results are estrogen patches. Estrogen will dramatically reduce hot flashes in probably 80-90% of men. There is a risk of breast tenderness and breast enlargement, and that has to be monitored for. Estrogen can be stopped if that starts to happen, or people could get some prophylactic radiation to the nipples, and that should stop it. There are a number of other measures for hot flashes that aren't as consistently effective, but pills like gabapentin also can temper hot flashes. Interestingly, studies have shown that acupuncture can reduce hot flashes. So there are resources, the most consistent being estrogen, but other perhaps easier to achieve things like a pill can be considered as well, and sometimes those work very well. Another pill of a different category, an antidepressant type medication called Effexor, has also been shown to reduce hot flashes in not everybody, but in some people that take it.
In regards to the access to these types of estrogen patches or cream or anything like that, do they talk to their urologist? Are they talking to their family doctor? Who do they go to for this?
I would say the doctor who's giving the hormone treatment should be responsible for helping ensure that all these side effects and their ramifications and the countermeasures are fully implemented.
When I think of a man who is now depleted of testosterone and then taking estrogen, I would think, is there any other side effects or anything that he's going to experience if he is taking estrogen on top of that situation?
Not other than the potential for breast tenderness or breast enlargement. Estrogen patches are very safe and don't really have much of any impact in that setting. Estrogen can't be taken by mouth because it can promote the onset of blood clots, and so it's got to be the patch form. It's an effective intervention and quite well tolerated, actually.
One of my biggest frustrations, just being a leader of an advocacy group and reading all these comments from thousands of men all over the world taking hormone therapy, is how often men are not told ahead of time of these side effects. One of the biggest things that I see is breast enlargement and gynecomastia, and men just having to suffer through this and never being told ahead of time. So you mentioned the prophylactic radiation to the nipples in regards to hot flashes, but do men need to get this done ahead of time before hormone therapy? What is that process like?
Yes, you're right. So the onset of breast enlargement just from having low testosterone can occur, and for those who have access to radiation therapists, a couple treatments to the nipples should forestall that concern. If people are already developing enlarging breasts, the radiation will stop it from getting bigger and bigger, but it will not cause them to regress. So we usually advise patients from the get-go to be very vigilant about any tenderness or enlargement and to call us immediately for an estrogen blocker which is certainly not going to help in terms of the hot flash control, but will help in terms of preventing breast enlargement, called Femara. This estrogen blocker was originally FDA approved for the treatment of breast cancer. It's extremely well tolerated and is quite effective. So we'll usually start with Femara medication, 2.5 milligrams a day, and that does the trick in most people. Nothing is universally effective, so if there were continued enlargement, then perhaps move on to doing the radiation we talked about.
Is there anything a man can do who has already had breast enlargement to reduce that, or is surgery the next option?
Pretty much, yeah. Plastic surgery for gynecomastia is effective and available. I would counsel people to shop around for skillful doctors because it's not a type of cosmetic surgery that's done frequently. And to get a good cosmetic outcome, in other words, going back to just looking normal again, does take some skill. The selection of the right plastic surgeon to do that is important.
Another, concern that I see from patients often is joint pain. In fact, I was talking to a patient in New York, and he lives in Manhattan, and he's just having a hard time even going to the doctor's office. So is there anything that can be done? What is causing that pain?
It's not clear. There are specialists in the medical world, that board-certified joint experts are called rheumatologists. And it's interesting that this phenomena of joint pain in men that have low testosterone is something I've observed for decades. And it reverses quickly. It does not cause any permanent damage to the joints. We just manage it symptomatically with things like Motrin or Tylenol and reassurance that it's not a sign of some deteriorating disaster. But in the rheumatology literature, they're not even aware of this phenomena. Of course, as men get older, we get aches and pains anyway. But it's a very distinct phenomenon that does occur in a certain percentage of people with soreness in the joints, and it quickly reverses when the testosterone levels get back to normal.
When I'm talking to men who are undergoing hormone therapy and they're dealing with things like joint pain, hot flashes, lack of libido, tiredness, just so many different side effects, the toll on their mental health can often be immense. What do you do to counsel patients who are going through this treatment of not only fighting prostate cancer, but now they're having to deal with it, feeling this intense, daily, weakened state? And it's affecting so many of their relationships. It's just, we see a huge wave of mental health issues when it comes to this. And a lot of times men just don't know what to do. They don't know who to talk to. And it's really become an awareness project for PCRI. And because of you, we've created this. So what advice do you give to men in that situation?
The one thing we do from the get-go, if someone's now embarking on hormone treatment, we don't literally do this, but we almost ask them to sign in blood that they'll get a trainer, that they'll get to the gym 3 or 4 days a week, that they'll lift weights for an hour on each occasion to the point of really getting worn out. And that compensates for a lot of the things that you've talked about. It fortifies them against the emotional swings. It fortifies them against the weakness, the fatigue, even the depression. It improves memory. People in this situation know that they're embarking upon a rather serious, life-changing situation. At least they should be informed to that fact. And as a component of that, it requires a lifestyle change on behalf of the patients to be very serious about fitness. That is the lion's share of what we're committed to do when we have patients on hormone treatment, is to ensure that these patients follow through on their exercise. And it works surprisingly well.
Along with fitness, do you ever see diet taking any sort of role in eliminating any sort of emotional toll, or is it really just to boost up their fitness and help their body overall? Where does diet play out in this?
Diet is a challenge for all of us all the time, and it's even worse when you don't have testosterone, because a lot of men will be facing a stronger appetite. So I don't have any easy answer. I'm very excited about these new medicines that you mentioned earlier, like Ozempic and Mounjaro. They work, and if people are desperate and they're putting on weight, then I hardly encourage that they embark upon pharmaceutical treatment to assist in keeping their weight under control. Other than the fact that we all feel better and have better self-image if we're not overweight, the process of keeping weight under control is always a challenge, and it's not a happy discussion point to talk about it. I mean, sometimes people are encouraged by the fact that good diets do have an inhibitory effect on cancer growth. What is a good diet? Well, start with not having excess calories. How do you know you're not getting excess calories? If you don't have a tummy that's hanging over your belt, you're getting there. So you can just look at your waistline and figure out if you've arrived at the type of diet that's optimal for you.
If you have questions on hormone therapy or hormone therapy side effects, please leave them in the comment section below this video. It is because of those comments that we were able to create this video today. And one of the things that I appreciate is all of your vulnerability as you're leaving comments, because I see that you're helping other patients and sharing your experiences, and it has really built a tremendous community through PCRI, and I really appreciate you. Your activity, your comments, your likes, your feedback is crucial as we continue to make content, but also for other patients to hear about your stories. And this is a great way that you're supporting the prostate cancer community. Now, speaking of support, individually, I want you all to get as much support as possible. As I read through these comments, I realize you guys are going through so much. And whether it's, contacting our helpline at pcri.org, or joining a forum like Health Unlocked or Inspire Network, or joining a support group, those are different ways that you can get support through the prostate cancer community. Because going through this alone is just not something I wish you would do. I hope that you get vocal, you find somebody that you can talk to, and you kind of build a pathway to deal with prostate cancer and specifically hormone therapy side effects, step by step, day by day, so that you can create the best quality of life that you can in the current situation. Now, please subscribe to our YouTube channel because we do have more content just like this coming out. And please remember, most of all, you're not alone.